This is Chapter 20, Clinical Periodontal Assessment. So your clinical periodontal assessment is your fact gathering. It's a comprehensive picture of the patient's periodontal health status. Your clinical periodontal assessment is one of the most important functions that you're going to perform. It forms the basis of the patient. It gives you your basis for your diagnosis and your basis for your individualized treatment plan. The objectives of the assessment procedure are to detect clinical signs of inflammation, identify existing damage caused by disease or trauma, provide data to assign periodontal diagnosis, and document features of the periodontium for long-term monitoring of the periodontal disease activity. Documenting the features is extremely important for long-term monitoring. Each time the patient comes in, you're going to compare their periocharting, their clinical attachment levels, all of your data that you gathered from where they were at the previous visit. And you can go even further back than that and keep documenting and comparing to long time. Changes over time are one of the things that we look for a lot in periodontitis. Dentists and dental hygienists have a legal responsibility to complete an accurate and thorough periodontal assessment on every patient. That is called the standard of care. You must provide the standard of care. The standard of care is like what's normal in your industry. And it's normal for you to do a complete assessment on your patient at each visit and to document your findings. You're going to document your findings and your treatment outcomes, and monitor your periodontal health status over time. Findings documented during the initial clinical periodontal assessment serve as the baseline. So think of it whenever you are trying to monitor something, you kind of need to know a baseline. Where did it start? You know, if you're monitoring a lesion, what did it look like initially? Has it changed? There are two types of periodontal assessments. There's the periodontal screening examination. That's a quick process. We usually don't use that process, or we shouldn't be. We should be doing the comprehensive periodontal assessment, which is the in-depth information gathering. So what do we do in our comprehensive periodontal assessment? There are 11 components to the periodontal assessment. Now, not every patient is going to have something in every one of these components. In fact, if you're lucky, they won't. But you should be looking at each of these things and coming up with some sort of a response to these. So do they have inflammation? Do they have, what's the level of their free gingival margin? In other words, do they have recession, or is it at a normal healthy height? Do they have inflammation? So is the gingival margin more coronal on the tooth? Recession, level of mucogingival junction. That's something we don't always measure that we should be looking at. Probing depth measurements. We all know we do that. That's something that we all are getting better at and faster at. Bleeding on probing. So do a bleeding index. Do a plaque index. Presence of exudate. If you're noticing any kind of pus anywhere. Tooth mobility. You should be checking the teeth for mobility. And furcation involvement. So go around with your probe and see if there's any furcation involvement. Presence of calculus deposits. Are they mild, moderate, heavy? And the presence of biofilm. Again, doing a plaque index is going to be your best comparison, because if you say slight plaque to you and slight plaque to me might be totally different. These are ways to evaluate the gingiva. You all should know by now you want tissue color, contour, consistency, and texture. I know you have descriptive words for each of those categories. You should, when you're forming your gingival description, try to use a descriptive word that describes the color, one that describes the contour, that describes the consistency, and one that describes the texture. The level of the free gingival margin is the margin slightly coronal to the CEJ, which is the normal position. Is it slightly significantly coronal to the CEJ, which is in gingival enlargement, or is it apical, such as in gingival recession? And you should chart your gingival recession. Refers to the displacement of the soft tissue margin. It results in root exposure. These are the Miller's classifications for recession. We don't use these in clinic. I've never used them even in clinical practice, but this is a good reference for you to look at and to realize that there are differences, significant differences in gingival recession. And you can have gingival recession like in class 1 and class 2, where it's recession of the facial aspect, but you notice the interdental papilla is all still intact, whereas in class 3 and class 4, the interdental papilla is blunted or completely flat. So the level of the mucogingival junction is the junction between the keratinized gingiva and the non-keratinized mucosa. So it's the line of demarcation between the attached gingiva and the soft alveolar mucosa. It's usually easy to see. If you pull out away your lip, you can actually see a color change between the attached gingiva and the alveolar mucosa. Probing depths are a measurement from the free gingival margin to the base of the pocket or sulcus. Bleeding on probing, we should mark bleeding sites and do a bleeding index on all patients. It's one way to be able to evaluate the level of inflammation. Exudate, you can press with your finger a lot of times to get exudate. Exudate is represents dead white blood cells. Tooth mobility. Check tooth mobility using two metal instruments, such as the end of your probe and the end of your mirror, and just rock the tooth. If you rock the tooth in a horizontal direction, so in other words, rock it back and forth, if you get up to 1 millimeter of horizontal displacement facial-lingually, that's considered class 1. If you have greater than 1 but less than 2, that's class 2. And then if you have greater than 2, or if the tooth is depressible in the socket, so in other words, if you take the occlusal or incisal edge and you push down toward the apex, if the tooth moves, that's considered class 3. It's hard to differentiate between class 1 and class 2 because your eyes are trying to see a millimeter of movement. But there's definitely a difference between like class 1 and class 3. Fremitus. Fremitus is like a vibration. If you take your finger and you place it on the facial surface of tooth number 8 and you have the patient tap their teeth together, you will feel little to no vibration. If you place your finger against a tooth and you have the patient tap their teeth together like they're chewing and you feel like a lot of vibration or movement, that's called fremitus, and that's usually an indication of occlusal trauma. Furcation involvement. Furcation involvement is measured with a Nabors probe. We do have, I think it's Nabers, but anyway, we do have Nabors probes available in clinic. So they're not in your kits, but they are available in clinic. So if you have furcations that are pretty involved, you might want to use a Nabors probe. What you're measuring is how far into the furcation area does the probe go. Furcations are measured in classes. So class 1 is where you take the tip of the probe and it dips in just a little bit, maybe a millimeter. Class 2 is where the tip of the probe goes into the furcation greater than a millimeter, but it doesn't go all the way through. A class 3 is where it goes all the way through, and a class 4 is where you can actually like visibly see. And so if you look back at this radiograph here, you can see the very large furcation opening. If you look with your eyes, you can see right here a furcation opening. Presence of calculus, you're going to look visually and make a judgment, and then you're going to take your explorer and you're going to determine how much calculus is present. The calculus codes that we use in clinic are not standard calculus codes. They are not something you're going to see in private practice. In other words, if you wrote Cal Code 2 in your clinical note in private practice, no one would really know exactly what that meant. They use light, moderate, or heavy. And then the presence of biofilm. You can do a plaque score, which is going to be the most accurate tool to measure plaque. You can also just do light, moderate, or heavy. But actually doing a plaque score is going to give you a much more exact evaluation. Document the presence of any local contributing factors like poor restorations. Radiographic evidence of bone loss is extremely important. So when you're doing your initial data collection, you'll notice a line in your clinical note about radiographic assessment. So you should be looking at your radiographs and assessing the bone levels. Do they have horizontal bone loss? Do they have localized vertical bone loss on tooth number 21? Do they have generalized horizontal, or and how severe is the bone loss? And then assessment components requiring calculations. The width of attached gingiva is a calculation, mucogingival defects, and clinical attachment level. So if you want to measure the width of attached gingiva that's present, you're going to take your probe and you're going to lay the tip of your probe at the mucogingival junction. So retract the lip, place the tip of your probe at the mucogingival junction, and then lay your probe against the attached gingiva to the gingival margin. And so let's say you get 6 millimeters. So you've laid your probe, and from the mucogingival junction to the gingival margin is 6 millimeters. But some of that is your pocket depth. So then you want to take your probing measurement, and let's say you're probing 3 millimeters. You're going to take that full 6 millimeters and you're going to subtract your 3 millimeter pocket depth. And the reason you do that is because if you can stick a probe in it, it's not attached gingiva. It's free gingiva. And so all we want is to measure the attached gingiva. So in that case, your attached gingiva would be 3 millimeters. And this is a picture of how you would measure it. And you can see over here on the left, you're going to lay the tip of your probe at the mucogingival junction, and you're going to measure up to the gingival margin. And then you're going to measure your pocket depth, and you're going to subtract your pocket depth from the total. And that's going to tell you how much attached gingiva you have. Clinical attachment levels. Clinical attachment level is probably your most important measurement. It's an estimate of the periodontal support around the tooth. So when you're measuring your clinical attachment, you're going to measure it from a fixed point on the tooth. In other words, the CEJ. The CEJ is a fixed point. Your probing depths will vary, your gingival margin will move, your level of attached gingiva can change, but unless you have a restoration that has altered the CEJ, your CEJ should be a fixed reference point. So you're going to measure your probing depth in the normal way. You're going to measure from the base of the pocket to the gingival margin. And then you're going to measure from the CEJ to the gingival margin. So let's say your pocket depth, you take a measurement, and your pocket depth is 3 millimeters, but you have 2 millimeters of recession. So you're going to measure the pocket depth, which is the gingival margin to the base of the pocket, and then you're going to measure from the gingival margin to the CEJ. And in that case, you're going to add those two numbers together. So a lot of students, a lot of clinicians even, think that they use probing depth and attachment loss interchangeably. So let's look at why they're different, or how they're different. So if the gingival margin of a tooth has receded 5 millimeters on the facial aspect, so let's say we've got tooth number 24 has 5 millimeters of recession and a 2 millimeter probing depth. If you don't look at or chart recession at all all I'm going to see when I come and I go to clean that patient after 3 months after you've seen them or 6 months after you've seen them, I'm going to see a 2 millimeter pocket on the chart, and I'm going to think that's perfectly healthy. But then I look at it and I go, well, that's not perfectly healthy. There's 5 millimeters of clinical attachment loss on that tooth. So clinical attachment level or loss, you can use those two terms interchangeably, is recorded from the CEJ. So if you were to say have, let's look at this next. What's the significance? It's a more accurate indicator of the periodontal support around the tooth. It provides an accurate means to monitor changes. So it gives you an exact number. Those of us who have majored in science love exact numbers. We don't like gray area, we like black and white. So things like your plaque index, your bleeding index, your clinical attachment levels, those give you exact numbers. That is something you can compare and measure. Those are also things you should be using in your goal. So when you're writing a goal on a treatment plan, don't just put decreased plaque. Because what does decreased plaque mean? My idea of moderate plaque and your idea of moderate plaque can be way different. So just saying decreased plaque, if you saw the patient and wrote decreased plaque in their goal, and I look at it, the patient, and I see plaque, I might think, well, that didn't decrease plaque. But maybe their teeth were completely covered with white sweaters when they came in, and now they only have a little marginal plaque. So it makes a big difference. If you can assign it a number, they had a 75% plaque index, and then today I do a plaque index and it's 25%, I can effectively say they have significantly decreased their plaque. Clinical attachment levels are the same way. So the pocket depth might state 2 millimeters on that tooth number 24. But maybe the recession is continuing to get worse. So instead of having 2 millimeters of recession, now the patient has 4 millimeters of recession. So their clinical attachment loss went from 4 millimeters to 6 millimeters. I can, with confidence, and say that the clinical attachment loss has decreased, or has increased, has increased. So I can say they now have greater clinical attachment loss. But if you only measured the pocket depth, it doesn't give me a good picture. So when the gingival margin is slightly coronal, or when the gingival margin, I don't hate to say above, because those are based on maxillary mandibular, can be different. But when the gingival margin is slightly coronal, or slightly above or higher up on the tooth, or slightly above or slightly higher, then that's the normal health position. We don't need to do anything. So if the gingival margin is there and you're probing a 4 millimeter pocket, that 4 millimeter probing depth is the clinical attachment level. But let's say the gingival margin is not slightly coronal to the CEJ. Let's say the gingival margin is at the CEJ, or below the CEJ, or significantly below the CEJ. We're going to subtract. I'm sorry, I said that backwards. If the gingival margin is significantly coronal to the CEJ, we're going to take the probing depth and minus the gingival margin. So in other words, if you have inflammation, and so the gingival margin is wrapping up on the crown part of the tooth, higher than just slightly, but significantly, you're going to subtract the gingival margin. In other words, we have to eliminate this part right here because the gingival margin should be down here. This is adding to your probing depth, but it's only adding inflammation. If you do scaling or root planing on this patient, this should go away and you should only have this, which is your true clinical attachment loss. So we're going to take this total 9 millimeter probing depth. We're going to subtract off our inflammation of 3 millimeters, and we're going to say our clinical attachment level or loss is 6 millimeters. In the case of recession, you're going to add them together. So you've got your pocket depth here of 6 millimeters. but you've lost part of this gingival margin height of 2 millimeters. So we're going to add these together. So your notations indicate the position of the gingival margin. So in other words, if your free gingival margin is only slightly coronal to the CEJ, you don't need to add or subtract anything. Your pocket depth is your pocket depth. Your pocket depth is your clinical attachment level in that case. But if your free gingival margin is significantly above or goes over the CEJ onto the enamel surface significantly, then you're going to subtract that inflammation. So if you have inflammation, you're going to subtract. So think of it kind of as inflammation is a negative thing. Inflammation is negative. So when you have inflammation, you're going to subtract. Your free gingival margin, if it's apical to the CEJ, then you've lost attachment, and you're going to add that to your pocket depth. So apical add, if it's apical, you're going to add the numbers. If it significantly covers it, your gingival margin covers the CEJ, it's a sign of inflammation. Inflammation is negative, so you're going to subtract. Or you can come up with some other way to memorize this. There is also a sheet that I added to the modules in Canvas that's called calculating clinical attachment levels or clinical attachment loss or something like that. It explains it in a little bit more detail. So please don't forget to take a look at that. And this concludes our discussion.